Before I introduce Dr. Gordon, I just wanted to show one slide. The leadership of Smart Africa, Dr. Sewamala, Dean Mary, and Dr. Sensoy Bahar asked me to give a very high level view of what the mission or vision of the Scale Up Hubs was back in at the time of its conception. And I'm just briefly going to provide a high-level view. As a collective, the Scale Up Hubs were designed to support a research program of multiple projects directed toward a single major objective or basic theme, requiring a broadly based multidisciplinary approach. Each hub was to contribute to the overarching theme of addressing implementation questions facing LMICs in their efforts to scale up sustainable evidence-based mental health interventions to address mental health gaps, treatment gaps for children, women, and men. To accomplish this, NIMH required the Scale Up Hubs to include three components that you can see in the Venn diagram in the upper left. That is implementation research, capacity building, and policy making. As a group, the hubs constitute an interrelated research network as depicted in the upper right-hand corner. Unlike a consortium, there is no coordinating body. However, the network functions as an overlapping community with common interests and collective efforts, shown as depicted as the blue circles. The model allows for both independence as well as unity. Smart Africa is a shining example. With many follow-on training awards, you have developed dozens of scholars in Uganda, Kenya, and Ghana. By the nature of your implementation research, you have touched the lives of so many participants and raised awareness to community organizers and policymakers all the way to Parliament. Smart Africa's fourth annual conference's title summarizes what Smart Africa has done so well, bridging the gap between research, implementation, and policy. Now it is my pleasure to introduce Dr. Joshua Gordon. Dr. Joshua Gordon is the director of the National Institute of Mental Health, the lead federal agency for research on mental disorders. There he oversees an extensive research portfolio of basic, translational, and clinical research that seeks to transform the understanding and treatment of mental illnesses. Dr. Gordon pursued a combined MD and PhD degree at the University of California, San Francisco, and I believe his undergraduate degree is from Washington University, but he'll have to confirm that. Dr. Gordon became convinced that his degrees were in psychiatry and neuroscience, and he became convinced that these fields presented the greatest need and held the greatest promise for biomedical science. He completed his psychiatry residency and research fellowship at Columbia University, and then went on to join the faculty in 2004. Dr. Gordon continues his research in his intramural lab, which focuses on the analysis of neural activity in mice carrying mutations of relevance to psychiatric disease. He has received numerous awards and recognition. Examples include the Brain and Behavior Research Foundation's NARCED Young Investigator Award and the Daniel E. Efron Research Award from the American College of Neuropsychopharmacology. In 2018, he was elected to the National Academy of Medicine. I'm pleased to have had the opportunity to introduce him, and I know you'll enjoy his presentation.
Thanks, Holly, for the introduction, and thanks to everyone for inviting me here today. Before I get started, I just want to make sure, are you seeing the presenter view or are you seeing the slide view? Because I can't tell from my screens.
We see the presenter view, Dr. Gordon.
Okay, let me swap that out for you. Is that better?
That's better, yes.
Thank you so much. So I really appreciate the opportunity to come talk with you today. And I recognize that this conference is on child behavioral health in Sub-Saharan Africa. The talk that I'm going to give is broader than that. It's really about our global priorities in mental health research, although I'll touch on several issues of interest to child behavioral health in through our programs. And I'm happy to take questions about really any aspect of the talk or other aspects of our policies at the end of the talk. So the talk will have four brief parts. I'll first talk about the process by which we began establishing global priorities in mental health research, and give you some examples of the kind of work that we've carried out as a result of that progress. And some of that, of course, has been going on through WashU and the hub of many researchers from really all over the globe that are working together, but also other programs around the globe. You already heard some from Holly about the organization and the summary of the one Scale Up Hub. I'll talk to you about the concept of the global research hubs and what we've been working on so far. And then really invite in the question and answer some discussion about next steps. How do we follow up on the progress the hubs have made to date? Because I think that's what we're really trying to work with now. Sorry, I skipped over the fact that I'll talk about the NIMH Center for Global Mental Health Research, which is undergoing some substantial changes that I think are very exciting. And then, sorry, the fourth thing, I'll talk about the effects of COVID-19 worldwide. I think it's important to number one, recognize that our global mental health research infrastructure has played a role in the research response to COVID-19, and give you some sense of what we're finding so far. So let's start with global priorities in mental health research. This is a map of the world where in white is every nation in the world that faces substantial mental health gaps, all of them, and you know this. This is true for high-income countries. It's true for low and middle-income countries. There are gaps when you compare mental health delivery, mental health access to other forms of health access. There are gaps in terms of areas of the world and areas within countries that receive less care. And there are mammoth gaps between those who need care, those who seek care, and those who obtain that care. And then there are also gaps in terms of the equitable application of evidence-based care within that process. And so, as many of you know, because you participated in it, really about close to 15 years ago already, NIMH really not leading it, more following the work of many other organizations around the globe, but working together with them, set out to really establish research priorities and grow our program on global mental health. And that process, which included, of course, the Grand Challenges process and lots of different players around the globe, led to establishing a number of global mental health research priorities. One of those is directly relevant to the topic of today, which is the understanding the social drivers of mental illness in lower and middle-income countries, with a focus on the life course, as Vikram mentioned, and in particular mechanisms and pathways of interventions for youth. This is a relatively new RFA that we put out that aims to shed light on the pathways and mechanisms through which a number of different social and economic factors induce risk for mental illness, as well as community-based targets for intervention to reduce that risk and build resilience. And I mention resilience in particular because I think a lot of the programs that have been proven effective on small scales and in community laboratory settings that we really like to see implemented globally are about building resilience in kids, and some of those were mentioned earlier. That's, of course, just one of several research priorities that we and others have articulated. Many of these are instantiated in various calls for applications that NIMH has put out. Highlighted in bold here are some that are active, including mental health research awards for early career investigators, notice of special interest inviting research on suicide risk in young people, and an active effort to understand the genetic architecture of mental disorders in ancestrally diverse populations. Others have, the calls have concluded and the research is ongoing, including, for example, interventions that some of which we'll get to a little bit later, to address the mental health and social and behavioral impacts of COVID-19, as well as social drivers of mental illness, that RFA that I just mentioned, which is relatively new, and we now expect a lot of wonderful research to come of it. So the priorities that were articulated through that process are instantiated through a number of programs, including these specific calls for applications. But I think on a broader scale, what the priority setting exercise led to was an understanding that we needed to establish collaborative efforts to conduct research, build and support research infrastructure and research capacity in lower and middle income countries. And that process really led to the establishment of research hubs really around the globe, some of which are illustrated here. An initial focus of a lot of that work was on psychosis. These are 7 different centers that were established to conduct psychosis-relevant research really around the globe early on in our global mental health research efforts. But our work is not only about psychosis. It's not only about genetics. It's not only about biomarkers. It's not only about risk factors and capacity building. It's also about trying to understand the intersection between social determinants of health and mental health, and frankly, that exercise of trying to understand that intersection is not all that valuable unless you can identify levers that you can press to change those social determinants and improve upon mental health. And so I wanted to feature one particular study that's being done in Kenya that really gets at the heart of this issue about identifying and then intervening on social determinants of health, and that has to do with food security. And one of our actually far-flung research centers in Sub-Saharan Africa has been focusing on food insecurity. It's doing it both from the mental health lens, but also from the HIV infection lens. Many of you may know that the National Institute of Mental Health supports a number of different research programs aimed at reducing the impact of the HIV epidemic and on a global scale. And one of those really focuses in on Kenya. I apologize because this map doesn't even have Kenya highlighted on it. This is a different hub. But this is work that I actually went and visited in Kenya, where individuals who are HIV positive, supported by a collaboration from University of California, San Francisco and the Kenyan Medical Research Institute, as well as a couple of NGOs, aims at addressing food insecurity in individuals with HIV and measuring the impact of those interventions on both HIV-related outcomes and mental health-related outcomes. And it's really an individual-focused approach, but a family outcome measure. Shown here is one of our principal investigators from UCSF, who's been in country for years and years, and one of the participants. And this participant, let me see if the video will work. Not playing. Well, this participant is standing on a pump. And the intervention is really a very simple one. These individuals are living in Western Kenya on small plots of land where irrigation is not very common, and food insecurity is a big problem because of one of the contributors to that food insecurity is a lack of adequate productivity on the land that they are able to farm. And one of the big impediments to that productivity is the lack of irrigation, although there is plenty of water. And this intervention is simple. It's providing them with a mechanical pump that allows them to pump water from underground stores or from cisterns or from irrigation ditches and rivers nearby, and pump that water onto cropland. And it's not just the provision of the pump; it's also education about using the pump and efficient farming techniques. And in terms of the target, providing them with the pump and this educational process does increase food productivity for those farms. And it not only does that, but also enhances economic security, because individuals are not only to be able to feed their family with that food, but they can also sell that food in the markets. And it also enhances, believe it or not, access to medical care through local clinics, because individuals are better able to afford the transportation it takes to get to those clinics, that are better able to take off time from other work and childcare responsibilities to do so because they have a more efficient farming system, that are better able to get their HIV care and their mental health care, and their children are more likely to attend school for longer. And then you can measure any number of different health outcomes related to their HIV status or related to their mental health, and they all improve. So this is an example of identifying social determinants of mental health and intervening with relatively simple low-cost interventions that can have a big impact. And we're really proud of the work that our Kenyan and U.S. investigators are doing in Western Kenya. There's our participant going up and down. Now it works on the pump. So these efforts and many others are supported with an infrastructure at NIMH to help solicit, evaluate, and fund research grants throughout the world. We've organized this infrastructure into the Center for Global Mental Health Research that sits actually side by side with our colleagues working on HIV, because there's a lot of international work in both these settings. This NIMH Center for Global Mental Health Research is focused on global mental health research, really from discovery to delivery science, as I'll get into in a moment. It engages diverse populations and communities with engagement both from public health sectors as well as individuals' lived experience and people. And it's also aimed at building and supporting capacity in country. And it's also aimed at integrating mental health services into healthcare and other service systems in these low resource settings worldwide. Very pleased to announce that we have just recently recruited a new director, Leonardo Cabillos, who is a psychiatrist, MD, and NMPH, and really with a lot of experience in the international policy scene as well as the international global mental health research scene. He's going to be joining us, I think, early next month. And we're very, very pleased to have Dr. Cabillos take over leadership in this effort, leading really a wonderful team of program officers and others focused on global mental health. This slide's kind of out of order. I should have been up in the front, but these are the grand challenges in global mental health that were identified through the process I talked about earlier. We've instantiated a number of different research programs to meet those challenges, including health effectiveness research programs, dissemination and implementation research programs, digital global mental health, health and human mobility, a number of different research programs that are focused on different aspects of what we think are, number one, important priorities identified through the processes we talked about, and also, number two, important opportunities from the research perspective. Now, a lot of the work that we do globally is along the lines of what the example that I showed you from Kenya. It's implementing interventions in the context of lower and middle income countries and understanding how those interventions move the needle. But we recognize that the global mental health research opportunities are much broader than that, and supporting and developing research infrastructure in lower and middle income countries demands that we broaden the scope of global mental health research. And so it's really our goal, and actually we're well along that way to that goal, to support not only implementation research in the near term, which can have implementation research, which can have near-term impacts, but also translation research and discovery research. And indeed, we've funded a number of efforts in these longer-term areas. On the discovery side, as I already mentioned, we're funding work to try to diversify the genetic understanding of our mental illnesses, to make sure that that understanding applies to populations across the globe and minority populations in the United States. We'll also support translation research. And there's really some wonderful advances that are being done in the context of lower and middle income countries that are really moving the needle in translation, especially around digital tools to deliver services, but also in terms of practical utilization of biomarkers to enhance the efficient delivery of mental health services in lower resource settings, and the development of novel therapeutic approaches, especially in task sharing, that then move into the implementation phase. So I think a true Center for Global Mental Health will support research really along this whole continuum. Now on to one of the principal methods so far that we've used to support global mental health research, these global research hubs. The initial collaborative hubs for international mental health research were distributed throughout Africa and Southern Asia. Later on, we expanded with a larger program, really with the focus on scaling up interventions in lower and middle income countries, and greatly expanded the geographic spread of these hubs. These hubs, as you know, because you participate in them, are really engage a wide array of players, including, of course, institutions in the United States, institutions in the individual home countries, and importantly, require collaboration with local public health agencies and affiliates to ensure that the research meets the needs of the local communities and importantly, has a pathway towards sustainability in the future. One advantage of these hubs is they develop infrastructure. And one of the principal advantages of the infrastructure is the ability to respond flexibly to new challenges, including the challenges globally caused by COVID-19. I'll talk more a little bit later on that. But several of our hubs have begun engaging around addressing COVID-19. For example, reciprocal learning approaches applied in lower and middle income countries to implement and disseminate sustainable practices can be applied directly to efforts to address COVID-19 and are being done so by the hub that involves Sub-Saharan Africa. That's a little bit ahead more. Sorry, right. One of those efforts that flexibly changed is efforts being led by a number of investigators, including Brandon Court, that take advantage of a tool that was being developed to aid in the dissemination of mental health evaluation and mental health services deliveries, which involved a electronic screening tool, the EMW tool, as well as a shared decision-making tool to help triage and treat mental health disorders. And these tools were developed so that non-mental health specialists could identify and treat mental illnesses in the context of their primary care settings. These platforms are then linked as well to a treatment platform, Stepwell, that delivers evidence-based practices electronically. Now, Brandon and others recognize that these remote platforms could easily be transformed in the context of COVID to address COVID-related mental health incidences in the context of the remote environment. But it couldn't have happened if we didn't initially fund a global mental health hub that supported Brandon and others' work. Brandon was then supported by a KO1 award for his career development and an R21 and then an R01 that enabled the development of these digital health tools. So it's really the infrastructure and the support for training that enabled then Brandon to come in with a supplement to his R01 and respond to the COVID-19 pandemic. And he's doing it in a way which we really value tremendously, which is not only providing support for research into the implementation and effectiveness of these interventions in lower and middle income countries, but also in the United States as well. And so this project that was granted to Brandon through a supplement allows or harnesses non-specialist providers in New York City through the Thrive NYC program, trains them to rate and assess individuals through a role play program, and then allows continuous supervision of those programs to allow non-specialists to deliver quality psychological support with ongoing supervision, all remotely. And so I think this gives you an example of the power of these hubs. It's not just about the research that they are conducting themselves. It's not just about the trainees, both in the US and globally, that are doing really wonderful research. It's also about building the capacity to flexibly respond to needs. And those needs exist not only in lower and middle income countries, but in underserved settings really across the globe, including in higher income countries like the US. So we're really proud of the work that the hubs have done. We're really proud of the work that we expect them to do in the future. And now I just want to come back to this COVID-19 topic because, of course, it's all on top of our minds right now. This is a map that's already old of the global cases of the pandemic. It's a few days old, but you all know that the pandemic is spreading like wildfire, really across the globe, but with some specific hotspots, both in the U.S. and India and parts of Europe, and now we hear also parts of Africa as well. One of the underappreciated impacts of the pandemic, although I doubt it's underappreciated in this group, is the impact on mental health. This data is from the United States, showing very high rates of complaints of anxiety and depressive symptoms in the context of the pandemic. They were already about twice the sort of pre-pandemic levels in August of last year, and they've been increasing as the pandemic has raged on. These impacts are not felt equally by individuals, whether we're talking in the United States or abroad. One example of that is looking carefully at suicide rates. Overall, suicide rates in the United States have not increased in the pandemic, at least to the extent we've been able to measure so far. But data from some individual US states, such as that here shown in Maryland, shows that while suicide rates in the state of Maryland declined during the pandemic for white people, Black people in Maryland experienced an increase in suicide rates, especially in the early course of the pandemic, when the economic impacts of the pandemic were most severely and acutely felt. And of course, Blacks in the United States and other minorities in the United States experienced those economic impacts at much far higher rates than did whites. And other measures in other countries, this is the data from Britain, showed again that Black, Asian, minority ethnic groups experienced higher rates of symptoms of distress, in this case, a mixed depression anxiety scale, compared to their white gender matched individuals, whether for both men and for women. Now, we know from prior studies that there are risk factors for worsened mental health outcomes in the context of disasters. These include uncertainty about the future, direct exposure to morbidity and mortality, pre-existing mental health problems, and social and economic vulnerability. And all of these risk factors really point to the lack of equity in terms of exposures and the lack of equity in terms of responses to mental health, and the need to focus on vulnerable populations. And in terms of focusing, we also know from prior disasters the kinds of things we can do to build resilience. We can give people a sense of control and hope for the future. We can meet their immediate needs. I cannot underscore this enough. The kind of economic packages, food supplementation, housing measures such as preventing evictions. These measures, which are being variably implemented throughout the United States and throughout the world, these measures can have very powerful impacts on ensuring resilience to the mental health consequences of the pandemic. And there's evidence from the United States that is working. For example, if you look at symptoms of anxiety and depression, they are less in individuals who have received food assistance compared to those individuals who are not receiving food supplementation matched for socioeconomic needs. So we know that if we meet immediate needs, we can reduce the mental health impacts of the pandemic. And then finally, practicing healthy coping habits can help as well. And NIMH and other organizations have been promoting those coping habits as much as we can. In addition to actively using what we've learned from the past, we also want to respond to this pandemic with research. Actually, sorry, I'm getting ahead of myself. This is noting that we have been spreading as much information as we can about these resilience factors and the risk factors through institute updates and lots of outreach throughout the United States. One of the mainstays of reducing the mental health impacts is to provide treatment to those who need it. And of course, in the context of pandemic, that's meant telehealth. We at NIMH and others have long supported telehealth research and have shown that mental health delivery through telehealth can be as efficacious as in person, but it has to be able to be provided. And so we have research that we've supported to try to ensure that these digital healthcare interventions to address the economic and behavioral effects of the pandemic are being studied and implemented in effective ways. Some of that research has already revealed, for example, that telehealth, at least in the context of an insured population, this is data from HMOs, can be equitably distributed by ethnicity. Although in lower socioeconomic settings, such as federally qualified healthcare centers, a lot of the telehealth that is being delivered is audio only and not video, probably reflecting access to high quality internet and high quality devices that are necessary for the video delivery of care. There's one other element of the mental health impacts of the pandemic that I just wanted to touch upon that I think most likely does have global implications, although the data are again only from the United States. And that is that there is a considerably higher mortality amongst those with psychiatric illnesses who contract COVID compared to those without psychiatric diagnoses. So these are individuals who have contracted COVID, looking at all-cause mortality for hospitalized individuals who don't have a psychiatric diagnosis versus do have a pre-existing psychiatric diagnosis, and you can see that the survival probability is considerably less. In fact, if you have schizophrenia, you are as much as threefold increased risk of dying from COVID if you get it compared to individuals who don't. And more distressingly, if you're Black and have schizophrenia, that is the greatest risk, and that's again about a twofold increase compared to if you are white and have schizophrenia in the United States. So vulnerability from pre-existing mental illness is compounded by vulnerability due in this case to race, and which has a number of different social and economic factors associated with it. So we need to really look at intersectional vulnerability if we're talking about the mental health effects of COVID and the physical effects of COVID as we move forward. So with that, I'll open it up for questions. Thank you very much for your attention.
Thank you so much, Dr. Gordon, for those excellent remarks on the presentation. So we have one question, and I'll read it to you. Among our audience, we have a lot of training fellows in Sub-Saharan Africa. So the question is, what advice would you give early career scientists just starting their careers in global mental health?
Oh, that's a great question, and thank you for that. And whoever asked it, thank you for asking. First and foremost, you have to follow your heart. Follow what excites you and interests you, and what you think is going to have the most impact on your constituencies. So in the global setting, that can mean lots of different things. But if you are engaged in research that you're excited about, you're much more likely to be successful and to have a successful career. Second of all, I think it's really important to develop a network of mentors. And I really mean that, a network of mentors. Yes, most of us in research have benefited from a primary mentor, usually either in graduate school or in our postgraduate research. And those are really, really important. But especially from an international perspective, from a global perspective, developing a network of mentors, some of whom might have different kinds of expertise. For example, a local mentor who knows the on-the-ground situation and the availability of resources in country, international mentors who are experts in the field that you want to become, and also have that understanding of the global scene, both from a funding perspective and also from a scientific and career development perspective. Really thinking about a network of mentors that can help you develop as a scientist. And then the third thing is, don't be afraid to go where the problem leads you. That's both scientifically and geographically. You've obviously already taken advantage of this, being, the background is probably virtual, but being associated with WashU and perhaps being in St. Louis in the moment. Going geographically for the right training, but also going scientifically to the right place and the right questions, and allowing yourself the flexibility to explore different solutions and different techniques and different approaches is really important as well. So that's the general advice in it. And I think, I would say it to any scientist, but I think it's especially true in the global mental health space.
Thank you so much. We appreciate that, that advice. So it looks like we don't have any other questions coming in from our audience, but thank you so much. We appreciate you for making the time and giving that excellent presentation.
Well, thank you all again for inviting me, and thank you all for devoting your lives and your efforts to this incredibly important effort.
Thank you. All right. So next to our agenda, I'm going to invite again Dr. Fred Sawamala, who is going to be the moderator of our next panel. So this panel is focused on our scale-up study in Uganda, and they're going to talk about the key implementation components and preliminary findings from Uganda. Dr. Fred, you have the floor.
Thank you so much, Dr. Proskovia Nabunya.